Well, we do live in interesting times, as the saying goes. What's happening is historic, and this process of finding our way through to a national healthcare policy is both challenging and fascinating, and I might add, late. We are fortunate to have some of the best minds in medical administration and public policy on today's panel to provide their insight into this issue. I will introduce them after I tell you who I am. I'm Lynn Jimenez. I'm KGO Radio's business reporter, and I've done this sort of thing a lot recently, having to do with health care, so I know it's a very spirited conversation, and I look forward to today's. First, Lenny Mendonca, director and senior partner in the San Francisco office of McKinsey and Company. He leads the firm's knowledge development. Isn't that wonderful? I'd love to do that. With good reason, obviously. He's very intelligent. He oversees the McKinsey Global Institute and the firm's communications. He's on the Shareholders Council, and he's written and spoken extensively on globalization, corporate social responsibility, economic development, energy, education, healthcare, a whole raft of others. He's chairman emeritus of the Bay Area Council, chairman of the Economic Institute of the Bay Area. He serves on a number of boards as a graduate of Harvard College and the Stanford School of Business. Next, Wade Rose. He's vice president of external and government relations for Catholic Healthcare West, where he oversees and develops strategic leadership relations between CHW and key organizations and individuals. That's like trying to corral cats. He also coordinates CHW's goals with government initiatives at the federal, state, and local level. He's chair of the San Francisco Chamber of Commerce, serves on the CHW representative as the CHW representative to the Bay Area Council, also to the San Francisco Committee on Jobs, to the Partnership for Quality Care in Washington, D.C., and Health CEOs for Health Reform, among others. I don't know how he has time to breathe. Next, Gregory Adams, president of the Northern California region for Kaiser Foundation Health Plan, Inc. and Kaiser Foundation Hospitals. He oversees 67,000 employees who serve 3.2 million members from 20 hospitals and 46 medical office buildings. He has $17 billion in annual revenue to deal with. He's a member of the National Association of Health Services Executives, is on the board of the California Hospital Association, the California Chamber of Commerce. He once owned a firm that provided strategic and operational improvement consulting to hospitals and the like, which brings a unique perspective to this conversation. Next, Mr. Lloyd Dean, president and CEO of Catholic Healthcare West, where he's responsible for $11 billion in assets and overall management, strategy, and direction of the healthcare system, which includes hospitals, clinics, health organizations, health plans, medical groups, and some 35,000 employees and 10,000 doctors in 3 states. Now, I'm going on a bit about these people because I want you to recognize how lucky we are and how privileged we are to have them here in this discussion today. I'm also moving rather rapidly, as you might note. We have decided that we will do away with the 3-minute opening statements, I'm sure much to your relief, and get right to the meat of this whole thing. We're going to start with questions. All right. We've heard a lot about shifting from a fee-for-service model to a pay-for-performance model. Will that work, and who's the brave person who's going to go first?
Must be Lenny.
You've been elected.
Will it work or will it happen?
Whichever.
So yes, it can work, and yes, it is not impossible that it could happen. It's unlikely that it will happen in as substantial and fundamental form as some of us would like.
Why?
It's this little thing in Washington called politics. There is still an opportunity in the Senate discussions and in the conference committee that will come afterwards to include some of the elements of the kind of reform that we're talking about. As Ken really explicitly showed in his discussion, when you actually understand where the inefficiency is in the system and get people aligned around trying to do something about that, you can make a big difference. The only way we're going to pay for the expansion coverage, which is important, is if we actually have a more effective healthcare system that does the same amount for less money or more for much less money. And that's where those incentives have to be aligned so that you have the kind of aggressive, innovative management that Ken was talking about, or the kind of reforms that happen today in the high-performing health systems all across the country.
Would anyone like to build on that?
Yeah, I would concur with Lenny, but I would make these additional comments. Number one is that I think that we do have some examples within the country. CMS, particular, has instituted some programs that have not only worked, but have statistics and have metrics that show that we can make a difference there. The problem, though, is that most of the programs that we see are zero-sum game. And what I mean by zero-sum game is it's a Robin Hood effect. It's not that there's new money. What you're doing is you're taking over here, you're taking from those that, let's say, aren't performing up to the metrics, and you're giving to those that are meeting the metrics. I suggest to you that we've got to put some more additional incentives and additional resources on the table. I think Lenny's second question is really the real crux of the matter, and that is the will behind the hypothesis. But I am hopeful that within reform, as you get to the substantive parts of it, the execution, that there will be some incentives around pay for performance, and I personally believe there's enough money in the system if we do some of the other things that are on the table to take it forward.